Hi, everyone. We left off with really getting a good understanding for what an intellectual disability is. And we were talking here about the common features. The first one is a deficit in intellectual functioning, a deficit in adaptive behavior, and then manifestation during the developmental period, so before age 18. Remember again that intellectual disability is a type of developmental disability. I'm gonna just go to full screen here. All right, so now we're going to look at the different systems of classification that are used to classify individuals or diagnose individuals with intellectual disability. Historically, there's been this traditional model that has been used that uses these specifiers such as mild, moderate, and severe, in addition to profound. And these really focused on the IQ score as opposed to the adaptive behavior level, which is also really, really important. When we talk more about next week about adaptive behavior, maladaptive behavior, and its assessment, you'll have a better understanding as to why adaptive behavior is so important. Adaptive behaviors are those skills that really get us through the day, activities of daily living, self-direction, those types of things. This one is still used by clinicians, and in some cases it's required for the use when you're looking for an individual to get services like state services, like in Wyoming, like the developmental disabilities waiver. The AAMR is what now is the same association as the AAIDD. The name changed, so the acronym changed when we switched over from the definition of, or the term mental retardation to intellectual disability. And currently we use this current system of classification. And for the purposes of this course, that's really what we're going to be using. We're going to look at the AAIDD's system of classification because they're really the authority on the issue. And the focus here is really looking at the individual as a whole with the understanding that with supports, things will get better. We don't look at intellectual disability through our current system of classification as a state-like behavior. Remember, I talked about that in the first part, more of a trait-like. So things get better and they get worse depending on new challenges that they're presented with. And really important that we match supports with things, using their strengths, things they're good at when we're looking at this system. So now when we're looking more at a definition, we're looking at how we operationally define definitions, and we're looking at that, we want to look specifically at how this relates to where the person is or what the person needs. So in some cases, when we're looking at a definition, we're looking at a school focus. And when we're looking at those definitions, definitions of intellectual disability are really derived from state guidelines. And in a lot of cases, the term mental retardation does still apply. So there's very little consistency across states. It's getting better, but for example, in one state, they could still use the term mental retardation, move into another state and have the same disability, same difficulties, and the term could change to intellectual disability or mentally disabled. Really important in schools that there can be really different psychometric definitions, and this has to do with the assessments that are used and the IQ cutoff scores, and it can be really difficult sometimes in schools, especially when kiddos move from state to state, to have consistency in defining their disability. When we're moving to an adult focus, so once individuals are out of K-12 education, the definition is really used to help qualify them for services or benefits so they can participate in their community and in their state and have the same opportunities that other individuals without disabilities may have. Again, different parts of the state also may use different definitions, so you kind of run into a similar difficulty during the school years as well. However, as a whole, most states now have federally adopted the term intellectual disability instead of mental retardation. So when we're looking at practical realities, while there has been a much larger focus on focusing on adaptive behavior and how we can make things better through supports, IQ does still really play the dominant role in the decision-making process. So whether or not someone qualifies as having an intellectual disability. You'll see as we get into subsequent weeks when we talk about adaptive behavior assessment, it's not always used the way that it has been suggested. And the problem there is that the measures that we have, while we have good standardized measures, it's difficult for sometimes people to interpret and know how to score and how to use them meaningfully to plan for supports. So when we're looking at adaptive behavior, there's been some chatter about how do we use this. We know it's really important to focus on adaptive behaviors because those are the real life things that we see. Again, those are those activities of daily living, being able to live independently, hold a job, drive, navigate your place of work and community. And some have suggested, because we don't have great measures, is to abandon the use of adaptive behavior altogether, develop new or innovative assessments, or rather to allow adaptive behavior to play more of a supporting role. So on those cases that kind of fall right on the cutoff, maybe help justify that eligibility determination for individuals with IQ scores that are above 70, or maybe if we have strengths in adaptive behavior but lower cognitive abilities, maybe not making those decisions. And so really the use of adaptive behavior and understanding it really is still in the works. It's ever evolving as to how we can best use it for diagnostic and also for planning for supports purposes. So again, this is the current AAIDD's definition. That's what's in your text. Make sure you have a really good understanding as to what it is. It's really important to know that. And really important to look historically, again, really looking at the Shalek article, at how far we've come with understanding our definition, and really start to think about why the term has changed. Thinking about, does it really matter if it's changed, and why is it important for it to change, and those types of things. This is a great springboard for your first discussion post if you want to talk about the term and the importance of changing it and the kind of the social implications of changing it. And a lot of you thinking about that, a lot of you have probably heard of the R Word campaign. And so we're going to now kind of transition it just into a quick clip. And I will warn you that some of the language is pretty intense, but it's meant to really highlight the importance or need for this term to evolve and for it to change and why it's had to change. And then I also really challenge you guys to think about why it's had to change. Does this mean the term intellectual disability is eventually going to have to change? And why is that the case? Is it the name? Is it society's perception of individuals with disabilities, specifically intellectual disabilities? So this is just to highlight the importance of why it's important to use current terminology.
It's not acceptable to call me a nigger.
It's not acceptable to call me a spick.
To call me a chink.
To call me a fag.
It's not acceptable
To call me a kike.
And it's not acceptable to call me a retard or call yourself or your friends retarded when they do something foolish.
The R word is the same as every minority slur. Treat it that way and don't use it.
Spread the word to end the word.
Okay, so you can take a second to really think about that video. Again, it uses some pretty intense language, but it really highlights, again, the importance of why the term has had to change and why it's really important that we don't use that word in our vernacular anymore, because the term intellectual disability really the purpose is to really give some power back to the community of individuals with an intellectual disability, because historically, again, as we'll see in just a couple more lectures when we kind of talk about why the definition has had to change and how society as a whole has viewed this population, it's been pretty grim. So just some food for thought there as to why it's so important to use current terminology and what the new term does to help individuals understand this population. So now we're going to do a little quick segue. The information from here comes from Chapter 1 of your recommended text, and it's just a commentary on evidence-based practices. And that text as a whole talks about the importance of the use of evidence-based practice when we're looking at interventions or treatments or supports for this population. So just want to take a really quick bit of time to talk about what an evidence-based practice is and understanding it. Understanding that I know that text as a whole, it can be a little bit difficult to navigate here. So I will break down in lectures for you what I think you should know from them. So if you have difficulty understanding some of the information in them, hopefully I can provide some clarity here. And if not, just shoot me an email and I'm happy to clarify. So when we're looking at evidence-based practice versus research-based, again, these two terms are used pretty interchangeably. And what's important is evidence-based practice is very different from research-based. Research-based means there's just something out there that says this might work for this, or there's research to support it. It doesn't necessarily mean that it's evident that it has a large body of evidence to be effective. And when we're thinking about how this applies to individuals with intellectual and developmental disabilities, it's really important because there are a lot of treatments, services, accommodations, and all sorts of things that are available to this population, and many of which have no evidence base behind them. However, as long as somebody did one study at one period of time and found something, maybe with not so good of research methods, they can tout it as being research-based, and individuals will then think that they should do it. But it's really important that when we're looking at any interventions, supports, accommodations for any population, that we're making sure we have a good understanding of what's evidence-based as opposed to what's just research-based. So when we're looking at considerations for evidence-based practices, it's really an individual's part of their professional obligation that's surrounded around their practice and personal ethics, that they adhere to evidence-based practice. When you're looking at professionals, whether school psychologists, clinical psychologists, speech paths, occupational therapists, all of those individuals have a professional obligation to adhere to evidence-based practice whenever it's made available. Understanding that there are some things we don't have evidence-based practices for, and in those situations we just do the best we can with the information that's available to us. Because it's really also important that there are a lot of treatments out there that can cause harm to clients. So making sure, again, that you're very aware of evidence-based practice and know them. And additionally, the failure to provide effective treatments, if they're available and made common knowledge to certain professionals and they fail to provide those, that can also be considered a pretty important or a pretty difficult or a not so good thing if you're a professional provider. So how do we know if something's evidence-based? And that can be pretty difficult. Your chapter talks a lot about looking at these three different types of things, and kind of our gold standard here, if we're looking at it, are meta-analyses. And these are multiple studies that are conducted, and they're essentially compared to one another. Again, this is an oversimplification, but just to make it accessible, lots of studies are done and replicated to show with large samples of individuals that show a treatment or some type of support or accommodation to be effective. In some cases, it can be a little bit difficult to do that. Again, meta-analyses, we want to make sure we're using randomized controlled trials, so we have a control group. But sometimes we have to do small N experiments. And what that means is then you're using a small population of with individuals under 20 to 50 people. And when you're thinking about our population, for individuals with intellectual disability, this is important because there aren't a lot of people with intellectual disabilities in the overall population. They comprise a very small percentage of our population. So it can be difficult to get large random quality randomized control trials and then conduct meta-analyses of them. So there certainly is utility of in using quality small N experiments and looking at that information. And your book talks a lot about in what situations that's important. So additional considerations for evidence-based practice. It's really important that we predict the best treatment for individuals. Again, we want to give people services and things that work. We don't need to know what the average person will respond to. We need to know what our individual or our person is going to respond to. And again, that can be difficult for individuals with intellectual disability because they aren't the typical or average person. It's Also really important to be a good consumer of information and for professionals to disseminate or give other people knowledge on evidence-based practices for a specific population. Again, also knowing that when we don't have an evidence-based practice for a particular person, thinking about what we should do there. Oops, sorry guys. I want you guys to think about that, and I just kind of mentioned that, is that we just kind of have to do the best that we can with the information that we have. So whatever our current body of research is suggesting. In addition, if we know a certain treatment, so say for example, depression in individuals with intellectual disability, we don't have a ton of information on that, but we can look at we do have evidence-based practices for typically developing individuals, or the average person, if you will, and try to find some downward extensions for that and see what we might need to do to accommodate or modify those treatments to make them accessible for that population. Because, again, we don't always have evidence-based practice for individuals with intellectual disability, given that they comprise a small piece of the population. So, with that being said, thank you guys. Next time, we're going to kind of talk about changing the definition and the multidimensional framework that we use for assessment. And then in subsequent weeks, we'll really get more into how do we define intelligence and IQ and how do we assess for it, because that's a really important part of our definition of intellectual disability, and additionally adaptive behavior. If you have any questions about anything that I went over in here, please feel free to send me an email and I'm happy to clarify. Bye.